Did you know that only about 29% of the US population is at a healthy weight? Obesity continues to be the leading cause of diabetes, heart disease, and other chronic conditions that can dampen your quality of life. Today on Beyond the Stethoscope, we will be chatting with board-certified bariatric surgeon Dr. Aley Tohamy about the options patients in our area have when it comes to safely managing obesity. Dr. Tohamy, thank you so much for joining me today.
Thank you so much.
I would love to get started and hear a little bit more about your background and what you got you into this line of work.
So, as you mentioned, obesity is one of the biggest pandemic or endemic diseases in the United States. And I was very intrigued during my training in Philadelphia to see that this is a disease that actually we can cure a lot of medical problems that are associated with it. So I decided to move on after my residency training in Philadelphia to Pittsburgh, University of Pittsburgh, to obtain my training in bariatric and minimally invasive surgery there. Then I moved back from Pittsburgh to serve my communities here in the Philadelphia suburbs to do that. So it was a passion of mine since 2007 to treat obesity.
Wow, that's a long time. And unfortunately, we've seen it grow throughout this country since 2007.
Yeah.
Any specific trends that you've noticed since you've been practicing in this area?
Actually, it's as much as we're trying to fight this disease, because the CDC has declared obesity as a disease back in 2013. Mm-hmm. We've been trying so hard to treat this disease with different ways, medical and surgical. Mm-hmm. But as you mentioned, it's actually, we can't stop it. It's growing and growing faster for multiple reasons. And there are now solutions that's helping and try to control this problem. And I think one of the things that I've noticed since 2007, that the population that suffering from this disease is getting younger and younger. It's mm-hmm. actually adolescent obesity is also a major problem right now. Mm-hmm. It's not only the older age, like 50s and 60 years old or 70 years old. No, we're talking now about younger population in their 20s that they are having diabetes. Even in their teens, they're having problems like sleep apnea. So I've noticed that actually younger population is getting into these problems earlier now in their life.
Mm-hmm. Yeah, and it's unfortunate it comes with a whole slew of other medical conditions, as you mentioned.
Yeah.
So in another podcast where we were kind of touched on bariatric surgery, we addressed some myths behind bariatric surgery. Would you like to expand a little bit more on that?
Yeah, it's back in the 80s and 90s, there was no rules per se to say who is candidate for surgery. And patients used to go to their primary care physician and they get referred to a general surgeon, actually. And the general surgeon will perform bariatric surgeries like gastric bypass and older procedures called VBG or vertical banded gastroplasty, without preparing the patients for the change in their lifestyle afterward, the amount of food that they're not going to be able to eat afterward, the certain type of food that they're not going to be able to eat. So there was a lot of problems with bariatric surgery back in the 80s and 90s that made the reputation of bariatric surgery not that great among American population. But at the end of the 1990s, the NIH with American Society of Bariatric and Metabolic Surgery, with the American College of Surgeons, they came up with a white paper of regulating and controlling who is qualified to have bariatric surgery and what kind of qualification the surgeons have to have in order to perform bariatric surgery. And after that came the Center of Excellence for bariatric programs, which regulated the practice of bariatric surgery moving forward. So in the past also, back in the 1980s, most of those surgeries were done with big open incisions, and the patient stayed in the hospital for a long period of time with other problems like wound infections, pneumonia. Also, that added to the problems of the reputation of bariatric surgery. But with the advance of surgical procedure and surgical techniques, we have now minimally invasive surgery, laparoscopic, and recently we've been applying robotic surgery as well for bariatric surgery, which made the length of stay of the patient in the hospital 1 to 2 days maximum. They go back home and then they can go back to work within 10, 14 days.
That's incredible. I didn't know that.
Yeah, it's amazing when what a big incision can do versus small, tiny incisions. Pain is less, recovery faster, less risk of hernias, especially after the patients lose weight. If you have a patient with big incision and start losing weight, they develop hernias in their incision more often. But if they have small incisions and they lose weight, they usually don't develop hernias.
Interesting. In terms of, I guess, keeping up with, after you've had the surgery, is it just like a cure-all, or is there a lot of maintenance that takes place to keep up the weight loss?
I always tell my patient this. I always tell them there is no magic pill when it comes to obesity. There is no magic surgery. It's all one package. Patients will have to change their lifestyle. They have to choose the right type of food that they're eating. And they have to exercise. They have to be active. Surgery or medication can do so much, but after that, it's up to the patient to maintain and continue a healthy lifestyle in order to either lose more weight or maintain the weight that they lost.
So that's actually a great segue for my next question. Is there an obesity prevention program at Trinity Medical Health? Would you be able to expand on that?
Yes, we actually we have a multidisciplinary approach in our practice at Trinity in Mercy Fitzgerald Hospital. We have both arms, medical and surgical, as well as nutritional arm as well, that we have a dedicated dietitian that help the patient how to learn how to read labels, how to choose food, how to go shopping, and even about the habits of how to eat, how long you should stay on the dinner table, for example. So there is a lot of behavioral modification that we teach in our practice, as well as dietary education. Also, we have now exercise physiology, that exercise program that help the patient to be active and choose the right type of exercise that can help them lose weight. And that's the beauty of our practice. It's a multidisciplinary approach rather than just surgery or medication only. Now it's a whole package, as I mentioned.
Holistic, I like that. And helping keep people off of the operating table, I'm sure is another goal. So I can't log on to social media these days or turn on the television without hearing about Ozempic and other weight loss drugs. Would you mind addressing some of the myths, or just maybe helping educate me and our viewers a little bit more about what these are, how they should be used?
It's amazing. These are actually medications that achieved significant weight loss for a lot of patients. And the interesting part of these medications that they were discovered by pure coincidence. Actually, in the early 2000s, there was a certain medication that was designed to treat diabetes, type 2 diabetes. That family of medication is called the GLP-1 medication. And they found out that some of these medications cause significant nausea for the patient, that they can't eat too much. They feel full very quickly. So the companies who made those medications decided to revisit the research component of these medications, and they addressed the fact that these side effects actually mimic certain hormones that our body produce when the patient feels full. On top of that, it also slows down the emptying of the stomach, so the food can stay in the stomach longer and the patient feel full longer. So if they try to eat more than what in the stomach, they're gonna feel nauseous and they will stop. So that same diabetic medication got relabeled with a lower dose to be an obesity treatment, and it went into the market in about 2010. Then moving forward, instead of having this injection once a day, with research, those companies also, they switch the formula to be once a week instead of once a day. So it's more appealing for the patient, better compliance for the patient as well, that they can be on this medication just once a week instead of every day. And then other companies came up with a different generation of these medications. There are now not only GLP-1, there are also GIT medication, GLP and GIT medications, and there are more medication coming down the pipeline as well. So it's something that's a new era of a treatment for obesity, which, again, in the past there was also other medications, but in the pill form for treatment of obesity that had certain side effects, and the FDA had to stop it. As I mentioned at the beginning, there is no magic pill, there is no magic injection, there is no magic surgery, and there is no medication without a side effect. So these medication definitely has some certain side effect and certain precaution that we have to watch. Not everybody can take those medications because, for example, if anybody who has a history of cancer, thyroid cancer in the family, or the patient himself have or herself has thyroid cancer, they can't take that medication. Yeah. Pancreatic cancer is the same thing. So there are certain limitations for who can take these medications. And some patients also can't tolerate these medications. The nausea can be so severe that the patient will have to stop it. Patients sometimes complain of indigestion. Again, it's not one dress fits all. So it depends on who can tolerate those medications. And the other factor, unfortunately, whether or not the insurance companies will cover those medications. Not every insurance company, not every insurance provider cover those medications. The good thing about our practice that we integrate those medications in our practice as well in order to help the patient to have multiple options regarding weight loss. And our practice actually performed pre-authorization and check the insurances for the patient to make sure that they are covered before we start them on that route, because that route of treatment, it's not 1 month or 2 months. It can take up to a year. So we have to make sure that that's a continuum of a treatment that's not going to get interrupted for any reason or another.
And this treatment, is it a drug that you're meant to be on for life?
Well, it's there are different opinions about that. If you talk to the company who makes the medication, of course, they're going to tell you, yes, that's a disease that stays forever with the patient. But some physicians are very skeptical, including myself, very skeptical on keeping patients on these medication forever. So we have plans for the patient, and we'll see how they're doing, if they reach their goal, how much they can tolerate the medication, because it's also gradual increase of the dose. So if they can tolerate a higher dose, then we continue with them. But if they can't tolerate the higher dose, we go down a lower dose, and then we'll see how they do. So it's a very dynamic two-way street between the physician and the patient to see exactly what their goals are, and how will they tolerate the medication itself.
It'll be interesting too to see the continued research about these weight loss drugs, and like you were saying, you and other physicians might have differing opinions from the medication companies, which I find very interesting.
Yeah, and these are new medications in the market, and we still have years to discover their effect and their side effects long term.
Absolutely. Yeah. Going back just for a minute to bariatric surgery, do you have, who would be an ideal candidate for undergoing bariatric surgery at your hospital?
It's basically based again on the NIH criteria and the ASMBS, or the American Society of Bariatric and Metabolic Surgery criteria. Is anybody who has a body mass index above 35 with medical comorbidity, like diabetes, type 2 diabetes, high blood pressure, sleep apnea. Those are the main ones. There are lists of medical comorbidities that's related to obesity that can be treated with bariatric surgery. But the famous ones are the type 2 diabetes, high blood pressure, and sleep apnea, and their body mass index above 35. They qualify for bariatric surgery. Anybody who has a body mass index above 40, even if they don't have medical comorbidities, they qualify for surgery.
Okay, understood. And do you have to lose weight before you undergo surgery, or is that?
There is controversial, opinion about that. I am from the school that I prefer that my patient lose weight before surgery for two reasons. It's a jump start for the patient to start, their journey of weight loss. It will make their journey shorter, definitely. But also it helps the surgeon during the procedure, because if the patient lose weight prior to surgery, the liver size will shrink a little bit. That will help us work easier in the surgery. That the percentage of fat inside the patient's abdomen will be less. So it will help the surgery to be smoother and faster.
Okay.
So I'm from the school that, yes, I will advocate for the patient to lose weight before surgery, but it doesn't stop me from doing the surgery if the patient doesn't lose weight.
Absolutely. Thank you for that. Any final thoughts before we close out our episode?
It's interesting that we've been trying several avenues to treat this condition, but again, without changing the lifestyle, without changing the type of food that we're eating. It's going to be a pandemic, an endemic disease in the United States, and unfortunately it started with the mass production of processed food in the 1950s, and it's keep going. So we have to definitely to be more active. We have definitely to choose the right type of food in order to be successful in weight loss.
It's an uphill battle, right?
It is.
Yeah.
It is.
But thank you for the work that you do. I appreciate it.
Thank you so much.
Thank you. If you would like to learn more about the obesity prevention program at Mercy Fitzgerald Hospital or schedule a consult with Dr. Tohamy, please head over to our website at the link in the description below. Make sure to hit the subscribe button to get the latest episodes of Beyond the Stethoscope every other Thursday.